at the Johns Hopkins School of Nursing. In her present role, she is responsible for the integration of simulation into both the pre-licensure and advanced practice nursing programs. Her current research focuses on the use of simulation in nursing education, both in academia and practice. In practice, her research focuses on improving the nursing response in the first few minutes of a cardiac arrest upon rapid cycle deliberate practice simulation. In academia, the focus is on comparing the simulation in clinical environments with goals of informing an appropriate clinical to simulation ratio and designing the best use of clinical time to meet students' needs. She publishes and presents locally, nationally, and internationally on simulation and resuscitation training. Nancy also serves on our steering committee, and she is one of the original founders of MCSRC and has helped develop our curriculum for Train the Trainer. So we're very happy that Nancy could be here today to share with us on the simulation ratio. So I'm going to hand it over to Nancy.
So good afternoon, everybody, and I am very, very excited to be here. It's such interesting times to be teaching, especially teaching in nursing education where touching patients and being hands-on is so important. And at this point in time, we're not really able to do that. Although hopefully soon, we will be back in the clinical environment. But what I want to talk to you about today is the original research that I did with a team of researchers comparing the simulation and the traditional supervised clinical environment. Some of the focus of that work will change going forward, and I think everybody will recognize that, because the importance of adding virtual reality and virtual experiences into this mix is going to be very, very important as we move forward. But today what we're going to talk about, and I won't spend a lot of time, because I think a lot of time we're going to want to spend just having a discussion, but we want to just get have some understanding of well, let me just tell you first, we did get this work was funded by the International Nursing Association for Clinical Simulation and Learning, the Deborah Spunt Research Award. But again, my goals for today is just to analyze the results from the observational experiences. We'll talk a little bit about how we structured the study, but the big thing is to really look at what the results were, what we found, and how we need to move forward. And really what we want to do is evaluate the implications for experiential learning in nursing school. Because what we found was that there was some real deficiencies in some areas and some real strengths in some areas, and that we probably need to start to really look at the way that we design our experiential learning education for our students. So just to begin, when we started this work, there was not really much in the literature about the efficacy of the traditional supervised clinical experience. It's considered the gold standard, has been considered the gold standard, but with very little evidence out there to justify that standing as the gold standard. We know that there are things that we can get in the traditional environment that we can't get in sim, but we don't have a lot of data that tells us why exactly it is the gold standard. So we do have some information, that some basic studies that looked at supervised clinical that gave us evidence that wasn't so positive, that there was a focus on task completion and not really a focus on clinical reasoning. There wasn't a focus on teamwork. And those are things that we would think that we would want to be able to accomplish in our clinical experiences for our students. It was found in several studies that there was a fair amount of downtime, and I think anybody on this call or on this session that have experience in clinical recognize that there is supervised clinical is a random experience. And there is a fair amount of downtime, especially the randomness is complicated by the fact that there are 6, 7, 8 students with one clinical faculty member, and you really need to have somebody with you. The students need to have somebody with them when they go into the room to perform anything, to do any work with a patient. There has been one other study that looked at comparing clinical, and simulation. And that was a study done, a very, very small study done in the pediatric setting. And their focus was mostly looking at QSIN, looking at safety and quality measures. They found similar, they had similar findings to the other studies that looked at clinical, was that there was a lot of downtime in clinical. There was a focus on task completion, and but they also found that there was a greater focus on clinical reasoning and critical thinking in the simulation environment. So that's where we started with that understanding and with that evidence out there. So what we decided to do is, it was a research team and actually, I'm going to go back. I was told this was a nice group and you would tolerate me going back and forth, so I will. But it was my name is on this slide, but there were other people that were on the team that were essential. Sandy Swoboda from Johns Hopkins University. She is our pre-licensure simulation coordinator. Tonya Breimeyer, who is a dean at Dayton University. Laura Lucas, another faculty member at Hopkins. Tonya Rutherford-Hemming, who is right now in a practice setting in the emergency department. So everybody take just a quick moment to thank her for the work that she's doing. And another person that we had on the team was Susie Cardon-Egrin, who actually is doing several things right now. She's working in practice, but she also works for Harvard, and she was an exceptionally valuable member of the team. So I mention these names so that you recognize that it was a team effort, and we needed every single member of the team to be able to accomplish the work. So I'm going to move forward again. So when we started out, we had some questions that we wanted to answer, and the questions are very basic. What are the differences in the number and types of activities, including downtime activities, that's performed in the clinical and simulation setting? So what are the differences in the number of types? And what are the differences in the time spent in learning activities in the traditional clinical setting as compared to the simulation setting? And to determine that, we used a theoretical framework of Miller's pyramid, and I'll describe that in just a minute. It was a multi-site observational study, and we did receive IRB approval at all the sites. We were at 3 sites, convenient sample of 63 students, and the students that we observed were in their first or second medical surgical nursing course. That's generalizable. And we excluded students that were in high-risk units or off the clinical floor for observational experience, because we really wanted to record what happened in the medical, surgical, nursing, clinical experience. We collected all the data, and it was a very interesting experience to spend 8 hours on a unit collecting the data, but we recorded every activity that the student did, and then we coded it as to the type of activity, and then we also gave it a Miller's code. And again, I'll explain what the Miller's code is in just a minute. Jaslyn, as we go through, if anybody has any questions, please let me know, but I'll just keep on going unless I see anything.
Yep, I'll watch that. Thank you.
Okay. So our protocol, we had a protocol for the simulation day and a protocol for the traditional clinical day. For the clinical day, we just went in the morning at the beginning of the shift. The students, we chose students prior to, like the day prior to. We did not tell the students they were going to be observed. They had agreed to participate in the study at the orientation for the course. So we just showed up. The clinical faculty didn't know, the students didn't know. We wanted to try to keep it as natural as possible. And then we recorded activities from the beginning to the end of the shift. So at the beginning, and sometimes there was a pre-conference, then there was the activities that happened throughout the day. And then we also recorded the discussions in the post-conference. We did record all the time that was waiting for the instructor or the nurse, time spent in non-patient care activities. That was all recorded as downtime. The simulation day protocol, because simulation is conducted differently everywhere, essentially everywhere, we wanted to find the common denominator. And so every school that participated in the study had at least 3 simulation scenarios that the students participated in the medical surgical nursing course. So that's what we did. We observed and recorded 3 scenarios for each course. And we recorded from the pre-brief to the end of the debrief. And we recorded all the conversations that they had, all the activities that they performed within the simulation scenario. And fortunately, which was kind of nice, all the schools that participated typically sent 2 students in to be the nurse for the scenario. Now, there were times when that varied. I think there was one instance where the students that went in had difficulties, struggled, and so the instructor stopped them and took them all into the room, and they all participated. So there were some variations, but largely it was 2 students going in at the same time. And that we recorded the data for the pair. They were recorded as one. So just to talk a little bit about the framework, and this is an interesting framework. I don't know if people are familiar with Miller's Pyramid, but it was developed a number of years ago, and it was really developed to look at medical education and to help evaluate competencies for medical students as they move through their program. But it's it was very appropriate for us, and I think it's a really good way to evaluate the skills and performance and activities that students do. So it's a pyramid, and at the bottom of the pyramid is NOS. That is what the category is, and NOS is defined as just having information, direct recall. So it's, you know what normal laboratory values are, what a normal potassium is. You know what medications your patient is on. You know what your report is. So NOS, the activities that were associated with NOS were fact gathering, and report was one of them, going through the chart, looking things up. So NOS is really just knowing, having information. But the next level up on the pyramid is knows how. And that is taking that information that you know and applying it to the patient that you're taking care of. So you know what a normal potassium is, but your patient has a potassium of 5.5. Your patient also is due to get gentamicin, or gentamicin is a good drug, but to use it as an example here. Do you want to give the gentamicin that is ordered at the dose that is ordered, or do you want to check and make sure that there's not going to be problems with renal function with that, or with that potassium level? The other ways that we recorded knows how were discussions in pre-brief, debrief, pre-conference, post-conference that were focused on application. Discussions that were focused on knows, or discussions that were, tell me about your patient. So I'm taking care of Mr. Jones. This is what his diagnosis is. This is what his medications are. This is what his treatments are for today. That was what was discussed during the pre-conference or the post-conference. That was categorized as knows. I'm hoping this is making sense. So just let me know if anybody has any questions, or we can talk about it when we're done. As we continue to go up the pyramid, we move out of the cognitive brain into the activities, into the doing. So the next level is shows how, and that is demonstration of competence. So that is the student going into the room with supervision, doing something. So they're doing meds with their instructor, they're teaching with their instructor, they're doing an exam with their instructor. They are demonstrating that they know how to do it, but they are not doing it independently. And then the upper level of the pyramid is does, and that is independent performance. That is the student taking care of a patient independently, gathering information, understanding the information, making appropriate judgment, and then taking the appropriate action. That's the highest level of the pyramid. And that's the way that we evaluated the activities. That's the way we coded the activities that we saw in simulation and in the traditional supervised clinical environment. So we had the learning environments were in simulation. We had a number of different very typical patient scenarios: sepsis, MI, diabetes, post-op. I'm not going to go into all this detail. You can see this here. And the objectives were very similar through all of the scenarios. And we know that we design objectives for simulation because we know what we want to accomplish. There was physical assessment, nursing interventions, vital signs, medication administration, and really every simulation involved communication and SBAR. But then obviously there was also a pre-brief and a debrief in all our simulations. The traditional clinical learning environment were a wide variety of medical surgical environments, oncology, trauma, transplant. And we were, and actually in the next slide, I think we talk about this, we were in a couple of different environments in terms of hospital, academic versus community. But again, the objectives and the activities were very similar. Assessments, interventions, vital signs, you can see these were very similar to what would happen in SIM, but it was very random. It occurred very randomly. And you'll see that when we look at the data as to what we saw most frequently in clinical versus simulation. And these are, as we start to look at our results, we had, you can see the number of SIM observations. We had 3 sites, 12, 6, and 3, 12 in one site, 6 observations in another, 3 in the third site. Clinical observations went along the same lines, 15 in one site, 4, and then 2. We were in academic and community environments. Most of the shifts that we saw were 7 to 3. One school had the 7 to 12:30 environment, and you will see as we move forward looking at the data that that is actually a fairly good length of a shift, because most of the activities in clinical happen between 7 and 11 a.m. Cohort size, I'm not sure if this is exceptionally important. At the one site, we had 140 students in one cohort, 84 students in the other. It was just one cohort in the other 2 sites, 74 and 60. Clinical group size was the same in all of them, 8 to 10. And we had a variation on medical surgical 1 and medical surgical 2 courses that we observed. So essentially we had 21 simulation observation and 21 traditional clinical observations, total of 42, and we observed 1,900 activities. We break that down to hours. Obviously it was way more clinical hours for obvious reasons, and way more clinical activities for obvious reasons. When we put it all together, we had 1,600 activities that qualify for Miller's coding, which means that we excluded activities. We did not code for Miller's activities that were non-clinical. We didn't include downtime activities, going to lunch, doing other school work that wasn't related to the patient, that day's patient experience, anything that wasn't directly involved with the clinical experience, we didn't code for Miller's. So we went from 1,900 to 1,600 activities that require Miller's coding, and that was 1,200 in clinical and 366 in simulation. And the Miller's coding is very important, as you'll see, as we move forward and continue to look at the data. So what we saw, and this is really the kind of the interesting results. So in red is are the clinical activities, and in blue are the simulation activities. And I think that some of this stuff is fairly obvious. The one thing that really strikes you is the far right here is downtime. Way more downtime in the clinical setting. We had less than 1% of the time in SIM was related to one episode of equipment failure, was downtime. But in the clinical environment, there was a lot of waiting that occurred. Standing around happened a lot. Students didn't have anything to do, and they were kind of standing around talking, but waiting for the instructor, waiting for the RN, and then doing other class assignments. That was a fairly common downtime activities that happened in clinical. But other things that happened way more often, and I think everybody gets this, but documentation in the clinical setting. We don't really spend a lot of time documenting in SIM. Some places do. In the setting where I am at Hopkins, we don't build documentation into our into our simulation experiences, because it takes a lot of time and we're focusing on other things. We are obviously looking at ways to build that in, because it is important. One factor that we don't, and probably that other people don't, is that the documentation is so different wherever you go in the hospital setting or in the outpatient setting. So, but anyway, documentation was way more. Activities of daily living was higher in the clinical setting. They just did more of that type of work in clinical than they did in sim, and safety interventions. This made sense to us. Every time the students entered into a patient's room, a safety intervention was washing hands. That's the way every time a student washed their hands, it was coded as a safety intervention. And every time they would walk in and out of a room, they were washing their hands. So it just happened more often. Students don't walk in and out of the room a lot in the in the simulation environment. They go in, they do their work, they leave the room. Interestingly, patient education was done more in the simulation environment, and we were a little distressed by that particular finding. We actually found there were some times when there was no patient education done, and we couldn't really, in the clinical environment, and we couldn't really figure that out. Some people postulated that maybe patients are discharged after 4. So a lot of the patient teaching is done after 4 before the patients are going home. I don't know. But in sim, they were teaching and talking to their patients all the time, patients and family members, providing education and updates throughout the experience. Meds, more meds, and now that was pretty equal between clinical and simulation. Students give meds in clinical, they give meds in sim, and it is one of our focuses in sim to give medication. Skills, a little bit more often, that is a focus for sim. In the traditional clinical environment, it's a little bit of a random whether or not they're going to see a patient that needs to have a Foley inserted. And that's the example that you always use. I don't particularly care about Foley insertions, students do, but it's just one of those skills that we focus on, but it just is it's a random skills, and skills in general in the traditional supervised clinical environment are very random. Physical assessment, much more often in simulation, they were getting their initial assessment, doing an intervention, redoing their assessment. So it just happened more. And in the traditional clinical environment, just doing it once when they went in the morning. And again, we were slightly dismayed that we didn't see a full assessment done all the time. Sometimes it was a very abbreviated assessment. So that was surprising for us. Going into the chart was fairly equal, a little bit more in the clinical environment. So that's just a snapshot of some of the activities, and we do think that made sense. But really the meat of the findings was the Miller's Pyramid, because this really looked at the value of the learning experience, the application and the doing. And there's 2 findings here that really are very striking. Number one, if we look at knows how, now again, the supervised clinical is in red, simulation is in blue. If you look at knows how, and remember, knows how is applying, not just knowing that your patient has a diagnosis of a whatever, the patient's had an MI, but knowing my patient's had an MI, this is what I'm looking for, this is what I'm anticipating, I'm getting these medications ready. In sim, 12.8% of the activities, 12.8% of the activities were knows how activities. That was 809 minutes. In clinical, only 8.6% of the activities that account for 762 minutes. So way more minutes in clinical overall, but less minutes in knows how. So that is fairly significant. The other finding that really jumps out at you is does. And if you remember, that is the performing independently. So in sim, 66% of their activities were done independently. They got report, they washed their hands, they walked into the room, they took care of the patient. That accounted for 440 minutes of the total minutes that we observed in sim. In clinical, it was only 46% of their activities that accounted for 2,000 minutes. 2,000 of the total, 2,000 minutes of what they spent in the clinical environment. So they did more activities in sim independently in 1/5 the amount of time. And that was the finding that really struck us. And one of our goals for this, we wanted to compare the environments, but one of our goals was to see if we could find evidence for that 2-to-1 clinical to simulation ratio. And we obviously here, looking at this data, we can't mathematically say this is a 2-to-1, but this gives us emerging evidence that it is a way more efficient environment in the simulation environment that gives us emerging evidence toward a 2-to-1 clinical to simulation ratio. And when we say 2-to-1 clinical to simulation, we mean 2 hours of clinical equals 1 hour of simulation. And this is kudos to us. This was the article that we published. So essentially, we were able to provide, show evidence. This is a small study. We would really like to do it larger. In today's world, we're going to add the virtual experiences to the comparison of simulation and traditional clinical. But we were beginning to find that evidence that people are looking for to justify, because some people are doing 2-to-1 clinical to simulation without any data to justify it. People were doing it because they didn't have clinical sites, they didn't have clinical faculty, but now at least we have some data to say, yes, we can do that. But in addition, that gives us evidence for what we were doing. I don't know if you use this for your activities, for your virtual activities for this spring, but when we did simulation activities with our students, virtual simulation activities, but it was SP activities that were real sims, just virtual off-site. We used the 2-to-1 ratio for that because we had the data to justify it, and that helped when we were trying to put hours to get together. Because one of the things that I know, we weren't alone at this at Hopkins, but how are we going to get students the hours that they need to be able to complete their clinical courses? So what I'd like to do now is really open it up, and Jazlyn, you can tell me how we should do this, but one of the things that we found was that there was much more critical thinking in simulation than in traditional clinical. That was a little disturbing to me, that in terms of we had great clinical faculty, tremendous clinical experts, but they did not know how, or they chose not to question their students. What are you doing and why are you doing it? And then when they, in their post-clinical post-conference sessions, there wasn't a lot of a deep diving down into what happened to your patient. Why do you think it happened? What did you do? Why did you do it? It was just a recitation of what happened. So how can we better facilitate more critical thinking in traditional clinical? But the other things you always need to think about is obviously this. Now I am, and I think everybody on this call in this session are simulationists who really loves sim, and based on this, it just gives us more strength for simulation and doing more simulation. But there's things we can't do in simulation that you have to go into the traditional clinical environment to do, and to do it well, to work as that member of the team, to have the communication with the other disciplines. Now, I will tell you that we're developing really great virtual reality sims that are going to be interprofessional virtual reality sims that'll help with that. But there's nothing that can replace walking into a patient room and saying, "Good morning, Mrs. Jones. My name is Nancy. I'm going to be taking care of you today," and having that and developing that relationship with that patient. You really, when it's real live, that's just different. But also, what key concepts or learning opportunities are not occurring in clinical that are essential student learning experience? These are things that we need to talk about to really enhance the traditional clinical learning environment, but also the clinical learning experience for students in general. And I think this kind of work and the kind of experiences that we are having right now with this pandemic and the way that our learning experiences are limited, we need to really look at it's imperative that we look at what do we do best in clinical, and so how do we do that best? And one of the things I said earlier, and I didn't put this up on the slide, I'm not sure why, but we did find that in the clinical environment, most activities occurred from 7 to 11. Why do we have students there until 2:30 and 3 o'clock? So we really need to start looking at that to be able to maximize or optimize the clinical environment, because we have fewer sites, less time, fewer instructors. Let's optimize that, and then optimize what we can do for our students in the simulation environment, and then obviously add the virtual environment to that. So with that, I think I'm going to go ahead and close and turn it over for questions. I hope we have time for questions. So we'll go ahead and turn it over for questions. And Jasmine, should I stop sharing or should I leave it up?
Stop sharing, Nancy.
Stop sharing?
Yep. Mm-hmm.